The most important indicator signs: bloating, fatigue, brain fog, or mental fatigue. Brain fog is more of a I can't think straight, and mental fatigue is more so it's just kind of hard for me to think. My brain feels tired. It's a subtle difference, but there it is in case it's helpful. Cravings for carbohydrates. Now, there's a really important distinction here, which is sometimes when people think cravings, they picture, oh, the person is trying to quit smoking and I gotta have a cigarette. But if you finish lunch or dinner and you're saying, I would just like a little something sweet. I'm not ravenous for it, but I'd like a sugary thing, fruit, coconut water, whatever it is. If you don't feel satisfied until you have something starchy or sweet, or let's say you're shopping and they have samples out and you just can't help yourself but have the sample of a cookie or whatever, that in my view should be looked at as a potential warning sign. When your metabolism is healthy, foods like that shouldn't have allure. And as someone who's lived on both sides of this, I can say when I'm doing things right for my gut health and also for my metabolism, I'll give you an example. I was at dinner the other night. I had zero craving for a slice of bread, even though Perry's Steakhouse does have pretty amazing bread that I would often dip in butter and put some salt on it. As I've made some adjustments, I look at that bread with literally zero appeal. So just something to bear in mind. I'm not saying you can't ever have any of these foods, but if you do not feel a neutrality toward these foods, then that could indicate something is amiss metabolically. A few other things would be a white tongue, toenail fungus, recurring vaginal yeast or jock itch, or athlete's foot. So make note of those. The more of those that you experience, the more likely. Also, there are predisposing or risk factors. These include prolonged use of antibiotics. Not to say one course will be a problem, but multiple rounds or for consecutive months or multiple months. Steroid use, meaning immunosuppressive steroids like prednisone. Hormonal birth control. Prolonged use of antacids. A high-carb diet. Alcohol consumption that's a bit excessive. And stress. Again, none of these things in small amounts will be a problem, but we're thinking, what is the aggregate load of these factors when looked at together? And the reason why I say that is I don't want people to think, oh my God, I can never have a sip of alcohol. I could never use an antacid. Not that I'm advocating that per se, but I just don't want to sort of inculcate fear around these things. Alrighty, so then how common is Candida? 75% of women in their reproductive years will have at least one bout of vaginal Candida. Now, one bout is probably not prognostic, but multiple bouts, I think, starts to look more risky. We've discussed many times before the paper by Satish Rao that found about 20% of people with unexplained gastrointestinal symptoms had Candida. Another 20% had Candida plus SIBO, small intestinal bacterial overgrowth. And then another 20% had just SIBO. So maybe 20% in the GI, at least from the one Rao study. And then looking at oral thrush or white tongue, skin Candida, like tinea versicolor, or toenail fungus, those impact about 10% of the population. So we could say 20, maybe 30-ish% of people could have fungus, just to give you a rough estimation of how prevalent this is. Now, what makes Candida difficult to treat? Candida is a normal part, a commensal member of the microbiome of various cavities, right? Oral, vaginal, digestive. So it's held in check by this ecosystem. When, for whatever reason, the ecosystem goes out of balance, that's when the Candida go from commensal to what's known as opportunistic, meaning they see an opportunity to exploit more niches, and they literally dig in or anchor themselves with these hyphae. And that's what you're seeing in this schematic here, where essentially they drop these little anchors or they form technically what's known as filaments that connect them into tissue. And this does two things, makes them harder to clear, but also those burrowing filaments trigger the immune response or more of an immune response, so hence more inflammatory symptoms. And within this same transition to opportunistic, there can be formation of biofilms, Biofilms are essentially a fence that various microbes, not only Candida and fungus, can build over themselves to protect them from the bacteria that might want to police them out, from the immune system, from changes in pH, from antimicrobial herbs, from antifungal medications. And this is what you're seeing here from the journal Fungi. On the left, you're seeing just the yeast form. For those of you just listening, essentially picture a coffee table and you've got a bunch of peas sort of scattered around there, a bunch of small dots. When you go to the hyphal and biofilm form, this looks more like a pile of yarn. It's beautiful that we have this microscopy that can help us see what these fungus can do when the environment becomes more hospitable to fungal overgrowth. Now, the good news here is there are things that can be done, but I just want to explain this for those of you who may say, well, I saw my conventional doctor, maybe it was a GP, maybe it was a GI, gave me fluconazole, helped for a bit. Now I feel like I'm back to where I started, or maybe only a little bit better than baseline. What do I do? Why is this happening? This is part of the reason why. There's some interesting data regarding how fungus can cause fatigue that I think is important to underscore. Why I feel this is relevant and worth underscoring is because so many conditions might cause fatigue. But considering this 2023, given it was an observational study, so it's not going to be the most rigorous, but nevertheless, 800,000 subjects with a prior infection. It could have been Candida or flu or Lyme or Salmonella or others that were diagnosed with any one of these infections. They found in those having a prior Candida infection, this was associated with a 39% risk of chronic fatigue syndrome. An interesting hypothesis by Dr. Mona Morstein is that due to the acetaldehyde that fungus releases, we'll talk about this more in a moment, that requires metabolism of certain vitamins, and therefore high levels of acetaldehyde can decrease B1, thiamine, B2, and iron, amongst a few others. And so it's this secondary nutritional deficiency that might lead to, in part, the chronic fatigue. And there's also data finding higher levels of fungus in those with IBS, in those with IBD, in those with depression, and in those with anxiety. So it's not all theory. We have at least some preliminary data connecting these dots. And by the way, this has been helpful. Please comment. I really enjoy hearing your thoughts, your experiences. And if you wouldn't mind, share this video with one person you think it may help, and also subscribe so you hear more videos from us. Okay, so let's go a little bit deeper into what I mentioned before, the acetaldehyde and some of the other metabolic byproducts Candida produces, which lead to fatigue and brain fog. With acetaldehyde, it's interesting to consider that this is a byproduct of alcohol consumption, which is why, and this goes back to, I believe his name was David Cook, a pivotal fungal book from like the 80s, that one can have what's known as drunk brain if they have a fungal overgrowth. In fact, I think he tells one case study about someone who was given a breathalyzer and wasn't considered legally drunk, but there was detectable alcohol on his breath because of a fairly pronounced fungal overgrowth. In any case, the acetaldehyde can be toxic to the brain. It can also assist in formation of biofilm and weaken the intestinal tight junctions, or essentially damage the cells. And there are other compounds produced by fungus, bearing in mind that none of these are meant to be, the devil reincarnate, but too much of these can then be a problem. There's propionic acid, ammonia. In fact, there's some evidence that suggests people who have a really poor tolerance to exercise, it might be because exercise produces ammonia, but so does fungus. So if your baseline of ammonia is high due to fungus, and then you exercise and say, oh boy, I got really tired, I got really foggy, had muscle pain, this might be why. And fungus can also produce uric acid, which David Perlmutter has discussed can be very deleterious for metabolic function. Oxalic acid, so oxalates, and arabinose, all of which, when excessive, might have negative health implications. So then this begs the question, how can I test this? There's pros and cons. What I like about testing categorically is, at least in theory, it can take the guesswork out of this equation and help us say, well, it could be SIBO, Candida, it could be metal toxicity, it could be mold, it could be low levels of testosterone, what have you. How do I know which one? There seems to be so much symptomatic overlap, and my history seems to suggest multiple different hypotheses in terms of why I'm having insert symptoms here. So this is where the testing, I think, has merit. So a stool test might be able to tell us what's going on in the entirety of the GI tract. Because one study actually did find that the frequency of brushing teeth and therefore improving hygiene of the mouth, that could lead to a 1 to a 10-fold change on stool levels of Candida. So, at least inferentially, a stool test could tell us the health of fungal populations from mouth all the way to colon. However, another study found that 82% of healthy individuals had elevated levels of fungus in their stool testing. So it's hard to derive a ton of definitive information from a stool test. Well, what about antibodies? What about looking in the blood for reactivity against Candida? Also has a lot of merit, and in my opinion, can tell you when the Candida is going to be, or going into a little bit more of an invasive colonization, meaning it's getting deeper in and it's really stimulating the immune system. And my view on this, just my opinion, is that the antibodies might be most demonstrative of small intestinal fungal overgrowth, which cannot be readily tested in clinical practice because, at least at current, the only way to assess this truly is directly sampling from the small intestine, which is very invasive. So there's merit on the one hand to the antibodies. However, counterpoint would be antibodies can stay elevated after an infection is cleared. So we don't know if the antibodies are telling us about a current or a prior infection. And then additionally, there are about 200 different species of Candida. And at current, the antibodies are testing for these individual species and only some of them. Now, not only that, but there are other non-Candida fungal genus like Geotrichum that we really can't fully assess on an antibody profile. Now, maybe you get a few positives and maybe those correlate clinically, but again, the perspective I'm trying to share here is that we can't hang our hat too confidently on antibodies. And then there's also a urine test, diarabinitol, which does have some merit, at least when looking at truly invasive Candida, but it hasn't been validated yet in more of a chronic low-level presentation. So what I'm saying there is we might run the risk of a false positive or a false negative. And while testing is so appealing, consider this one point, that if you get a false positive, meaning the test says you have the thing, but you actually don't, what that can lead to is months of treatment without feeling any better because you treated something that wasn't actually there due to a false positive. So on the one hand, I appreciate when someone's not feeling well, they really want answers, get it? But we should be bridled because those false positives especially can lead to months of wasted time, resources, treatment, energy, and sometimes frustration and sort of this emotional toll. So my perspective has always been with fungus and many other issues or disease states we're trying to quantify within the gut, it's part of a clinical diagnosis, meaning you, your symptoms, your history, your response to treatment, these are the most important variables. And the lab work is looked at secondarily to those data points, creating a mosaic that really allows us to give you a prognosis or diagnosis on a probability spectrum and not looking at it and saying, well, if it's yes or no, right? You have the test positive or you don't. Very dichotomous, very cut dry. I wish it was that easy, but it's not. The system is complicated. There's different windows. These windows have different levels of predictive validity. So that's the long short on testing. I did want to make one note on estrogen. And this is that, according to one animal study and one in vitro study, that treatment with estrogen or high levels of estrogen can actually make one more resistant to fungal treatment, or it can make fungus worse. Now, this is not to say that you need to have no estrogen in your body, because then a woman or a man would feel terrible. But it's coming back to that Goldilocks principle of estrogen balance.